Field School Program on Mental Health in Indonesia, a collaborative initiative by the University of Sydney and the Faculty of Psychology, Universitas Gadjah Mada. This program is designed to enhance our understanding of mental health issue in Indonesia and to explore the challenges and opportunities related to mental health services access. Before we begin, allow me to introduce myself. My name is S.Psi Rahmani, but you can call me Sasha. I'm honored to be your MC and moderator for today, and I'm also a lecturer at the Faculty of Psychology, Universitas Gadjah Mada. I look forward to guiding you through today's program and facilitating our discussion. Mental health is a critical issue that affects individuals, families, and communities worldwide. And in Indonesia, we face unique challenges such as stigma, limited access to service, varying quality of care. And today we will delve into these topics and discuss how we can collectively work towards improving mental health awareness and services in our society. Okay, thank you for joining us today, Professor Susan, Dr. Margaret Spencer, Mr. Dadung, Dr. Rahmat Hidayat, Dr. Praditya Prativi, Dr. Restu Tri Handoyo, and Ms. Aliyaturrahmah Supriyadi. Okay, we hope you will find this program insightful and enriching your knowledge about mental health practice. Okay, ladies and gentlemen, to begin, we are honored to have the Dean of the Faculty of Psychology, Universitas Gadjah Mada, Dr. Rahmat Hidayat, with us today to deliver the opening remarks. The Faculty of Psychology has been at the forefront of addressing mental health issues in Indonesia, and their support for this program is invaluable. Please welcome Dr. Rahmat Hidayat.
Thank you, Sefra. Hi everyone. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. What I have to say apart from warm welcome to you all on behalf of the Faculty of Psychology, Universitas Gadjah Mada, all the students, and also Professor Susan, Dr. Margaret Spencer, and Mr. Dadung Muktiono. It's of course a pleasure for us, all the students of Universitas Gadjah Mada, as well as the staff, to welcome you here and to have talk with you all and share, especially on the very important topic, mental health, which this is part of our focus at the Faculty of Psychology. We do have this Center for Public Mental Health, in which they are doing a lot of work, both going directly into the field, as well as advocating the government to develop policies and programs with the objective of supporting the community and dealing with mental health problems. And actually, this mental health program is one point in which the Faculty of Psychology has been having a long collaboration with institutions in Australia, because mostly we started with the mental health program in Aceh during the tsunami. And right after the tsunami, the faculty sent several staff, including myself, to the field to do the rapid assessment of psychosocial and mental health problems. Based on this assessment, we brought a proposal, and right away we found partner from Australia, especially Melbourne University and the World Vision Australia, and from then on we developed a program for 3.5 years in Aceh, setting up the mental health program and raising awareness about mental health problem, as well as supporting the local universities to develop a psychology program in the area. And I may say too much about this, but based on this work, I was then awarded Australian Leadership Award Fellowship with the Melbourne University in 2010, and that's the work continues by the establishment of this Center for Public Mental Health, and continue their work, not only in Aceh, of course, but also with our local government and including the national government. So it's like coming around these situations in which we, the world, can meet you all here from Sydney University, and I hope we can all share each other our experience, our perspective, our commitment to this very important issue, but largely still misunderstood, especially the community settings like in Indonesia. So we might learn a lot from you, as well as we can share our experience, learning experience with you, which might be also beneficial. And if you allow me to continue my talk, I may end up at 11 o'clock in the evening, so I'd better give it back to Shasha. Again, very warm welcome to you all. Hope you can enjoy everything here. Thank you.
Thank you, Pak Rahmat, for your inspiring words and starting the topic for today's event. Next, we are privileged to have Dr. Margaret Spencer for the University of Sydney, who will share her perspective on these important collaborations. Dr. Spencer, the floor is yours.
Start with, I have been learning Bahasa for 3 days. Nama saya Margaret Spencer. Senang bertemu Anda. Ini rakan saya. Nama dia Ibu Susi Goodwin. Bak Dadung Muktiono. Kami dosen di Universitas Sydney. Profesor Susan, guru sosiologi, dan saya guru, dosen pekerjaan sosial, and Bak Dadung is mahasiswa doktoral. Mereka mahasiswa belajar pekerjaan sosial, bahasa Indonesia, education, and terapi okupasi. Terima kasih telah mengundang kami ke UGM. Kami senang sekali berada di sini. Maaf, saya hanya berbicara sedikit bahasa Indonesia. Tapi song.
At today's event, we will have a souvenir giving moments. We would like to invite Dr. Rahmat to present a token of appreciation to Dr. Margaret Spencer. The CPSH presentation will be delivered by an amazing speaker. Ms. Aliyaturrahmah Supriyadi will provide us with an overview of the current mental health situations in Indonesia, highlighting the key issue and ongoing initiative. Mbak Alia, the time is yours.
Good afternoon, everyone. It's very nice to meet you. I feel like I'm a bit of a bummer because I'm going to talk about a lot of things and you've been very happy and relaxed. And so I do want to make this a bit more relaxed and more more of a discussion. You know, if you have any questions, any thoughts that pop up into your head in the middle of me talking, please put up your hand and that makes it a bit more interesting for me as well. So my name is Aliyaturrahmah Supriyadi. I would say I'm a junior lecturer here. I started here about a year ago, so fairly new, but I'm interested in community mental health, clinical psychology. I did my master's at Johns Hopkins University, doing a master's in mental health, so a bit more of a health field that I go into. So that's all I want to present to you today. But of course, feel free if you have any questions. And of course, I've heard that some of you are from social work, occupational therapists, and I think your experiences and your learning progress up till now will certainly be a point of discussion for us all today. Okay, so these are based on, I want to introduce you a little bit about Indonesia. I know you've been here for how many days? 3 days. Okay, so you know, you've started getting a feel of the, although, you know, because Indonesia is so large, it can be very different from each city and each place. So, okay, so I'll just go straight to here. This is a map of Indonesia, right? It spans more than 17,000 islands. 17,000. Australia is like one huge island, it's like its little islands surrounding it. But Indonesia has always been made up of huge and very, you know, because the islands, they are separated by sea, water, and so that's one thing to keep in mind. Our population is 273.5 million. What is the population in Australia? 27. Yes, only about a tenth, right, of the population. So you can imagine how big Indonesia is, and also I think we should note that more than half of the population in Indonesia currently reside in, you want to take a guess? You know? Yeah, Java, exactly. So it's, I can't see if I'm going to make here, but it's just this, oh, I can't see. Can you? Just point up Java. Okay, so it's just that little piece of area over there, more than half. So the other islands are so much less populated than Java, and so there's a consequence to that is about funding, development, especially education, and all this access to healthcare is going to really be affected by the population and the development. So, putting that into mind, what do you think are going to be some of the biggest mental health challenges in Indonesia? Okay.
Access to services.
Okay, great. Access to services. Do you want to kind of elaborate a little bit more? What do you think?
Like access to mental health units or maybe smaller facilities that have counselling or rehabilitation.
Yeah, great. Because of the big population, we have limited capacity to be able to deliver, especially mental health care. Anyone else?
Climate change and natural disasters.
Okay, great. Yeah, that's a great point about climate change and disasters. Indonesia is in the ring of fire, so we are very, I mean, we experience small earthquakes quite regularly, so we're, in a way, we're kind of used to it. But it's certainly a risk factor that we have to put into consideration. Yes, sir.
Like, really diverse population, so I think your mental health interventions have to be like tailored towards different groups of the population, maybe?
Yes, great point. It's a really great point. Because you see the islands separated, and if you know, we not only have separated islands, but different languages. We have so many different local languages, and it can be quite different cultural experiences that we have to take into account when we are thinking about appropriate interventions or what the needs are for each of these communities, right? So it's a huge, huge task to be able to at least provide some kind of mental health care that can suit the needs of the population as well. Anyone have any last thoughts, ideas, other mental health challenges you think? Yes, understanding of mental health. That's really good. Yeah, so with the cultural differences in language and how people view mental health, there's a lot of influence from religious perspectives as well. But that's also one of the things that we talk about is also can be also a strength in how we help people to understand their mental health. Okay. So these are some of the data that we have, and it's not perfect. This is based on a national health survey that's done every 5 years, but this data is quite old. This was taken in 2018. Regular schedules should be done in 2023, but due to the pandemic, it's been delayed, and we're not quite sure when the next one is going to be done. But we can see that with depression, there's 6.1%, quite significant. Schizophrenia or psychosis, so it's a bit of a question mark about the survey that was done. So we're doing schizophrenia or psychosis, and mental emotional disorder is 9.8%. And for people who have schizophrenia or psychosis, the treatment coverage, at least 85% has had at least one treatment or has accessed mental health care at least once in their lifetime, with most of them being people in urban cities. And you can probably guess why that is. And then people who have routine treatment falls under 50%. So there's a big question there. Why aren't people going to routine treatment? And treatment here is mostly understood by medical drugs treatment. Okay. And then for the suicide estimate, this is an estimate because we don't have we don't have factual recordings of suicide cases in Indonesia. Would anyone like to guess why? Or maybe take a stab? There's a lot of taboo around as well. Yeah.
I was going to say taboo.
Yeah, taboo, yeah. Taboo, and it's rarely reported as suicides because it can be very, very stigmatizing for families to report that the death in their family was suicide. There's also another factor into it in that people who are reported as suicides or self-harm aren't able to be covered by the health insurance. So that's actually a very interesting regulation that hinders the accurate recording of cases of self-harm and suicide. So, data also on the people experiencing schizophrenia and psychosis, we see confinement. Right? This is not an issue that's exclusive to Indonesia, I'm sure, but there is a certain, it's a very interesting issue also in Indonesia because there's like certain methods of confinement that can be quite, in a way, unique, but it's also to do with the capabilities of families to be able to care for people with schizophrenia or psychosis. And confinement at least once in their lifetime was 14%. And within the last 3 months that the survey was done, it was quite high, which is 31.5%. So do you know what forms of confinement are usually applied in people with suffering from psychosis?
Like is it put in a different room?
Yep, split into different rooms. It is very, anyone else? Yes?
And then they're restricted to a bed?
Yes, tied to the bed. And in Indonesia, we have seen the phenomenon of shackling. So actually using chains to restrain someone to maybe a bed or a certain place. But what we have to understand is that usually it's not that the families, have ill intentions towards the person. It's really about them not being able to provide the right care and being worried that they might hurt other people or that they might hurt themselves. And so a lot of our interviews with people who have been shackled was families don't have that resource and access to be able to provide good care for their family members. And it's ironically, it's out of love that they're trying to shackle that person in their homes. And so I purposefully did not include any photos because it can be quite triggering, but if you are interested to look into that further, there's some great documentaries that we work on as well that go in deeper with the experiences of people that have been shackled. Okay, so the numbers between urban and rural are too different. You can see there's, of course, at least one's rural is higher, but once you get within the last 3 months, it's actually quite similar. Okay. Now this is more data, but this is more national representative data on adolescents. We did this, we were involved in this national survey with University of Queensland as well. And this was done in, I think it was right at the start of the pandemic, so that was quite a challenge in being able to get this data. But we see that with adults between 10 to 17 years, the highest was with anxiety. And these numbers are quite similar with global numbers. So there's not too much difference in them. And so I think the takeaway is that we're experiencing the same prevalences that other countries globally are experiencing. But we also have to take note that this survey, we did, most of the respondents were early adolescents, meaning they were 10 to 13 years of age compared to the later adolescents. So that might also, we should also take into consideration that, that sample population. Burden of mental disorders, this is based on the IGME, relatively the same as well, right, with global numbers. 17% for Indonesia, 17.2, this is years with disability. So 70% of years with disability are from mental disorder cases. Ooh, this gets interesting. So this is about the mental health professionals that we have in Indonesia. We have psychiatrists, 0.4 per 100,000 population. So that's not even one person per 100,000 people. 0.2 psychologists, and we also have, clinical psychologists. And, this is clinical psychologists. We have other educational psychologists, but these numbers are for clinical psychologists. Mental health nurses is a bit better, And so we do look towards other health professionals that can be trained to help deliver at least some kind of first aid, emergency health care for in mental health cases. Social workers 0.1, 0.1 occupational therapists. For general practitioners, it's 40.8. I just made a mistake at the bottom. But there's a lot of efforts to train also general practitioners to be able to provide mental health care. So any numbers of this, any idea? I'm sure it's a better ratio in Australia, but any thoughts or ideas that you would like to share? Oh, and also, if we're talking about mental health professionals, we also have to talk about distribution, right? That's a really important issue, is that for GPs, for example, in Java, in big cities, they're almost competing for jobs because it's so saturated in big cities, but it's desperately needed in other more rural places. You don't even have to go far from Java. Even within Java itself, in some rural places, they don't have GPs or primary care centers. Yes?
Is there a lack of social workers and OTs because is there not much push for people to go into those fields? Like in Australia, everyone puts nurses, social workers and teachers all on the same line of need. Is it the same in Indonesia?
Yes, I would say yes. There's no real, this is my opinion, personal opinion. Okay, so the way to, the education path for a social worker is exclusively under the the social Ministry for Social Affairs. So it's not a subject that is offered to universities like ours. So you go through very specific schools and education, and I think that also hinders the ability for people to access that education. Let me make sure that again. Is it? And so why it's kind of exclusive is because once they're a social worker, they are a government official. So they have a contract with the government to work as a social worker. And so that, I think, it might be good in terms of, although I didn't have more data on this, but it might be good in terms of like making sure that they're trained, but it's a bit more exclusive and not as available to everyone. It's not very competitive either.
So social workers and mental health professionals have a decent salary?
I'm not sure what social workers do. I'm sorry, because my field is more psychology.
Just take that on check, we'll be talking about social work at Goodwin.
Okay, so that's homework for everyone to ask the social worker about their
There are fairly new professions too in Indonesia. Social work is a relatively new profession, as is therapy occupacy here, whereas probably doctors, of course, more tradition, and of course psychologists more tradition of psychology. So that might be the reason too.
Yes, I completely agree. Any other questions?
This is just, I had this thought when the confinement thing was happening, like, how much of that confinement is mental health directed compared to, like, done by families?
Sorry, what was that? How much of it is?
Like, the confinement of, like, people with disorders, like, is that directed by health professionals? Or is it families doing it because they don't know what to do?
Right. So, mostly we exclusively focus on families, but we do have accounts of not mental health professionals, but health professionals, especially those who aren't trained and don't have maybe the facility to provide care. Then there have been accounts of health professionals in primary care centers in tying up the patient to the bed and things like that, unfortunately. Yes.
You've come a long way though in that, in Indonesia. Just in my time being here, we've made significant gains in improving the care of people with mental health, yes? No?
Yes and no. So, from our observation, so we had a huge program, very well funded in about 2008, I think, called Breaking the Chains. Literally breaking the chains. That was the program, to have people who have been confined out. But we know that that's not enough, right? Because there's a moment of relapse. If there's still no available health care available, they just go back to being confined. And so that's why we had to, in the national survey, they take within the last 3 months. Because it's something that can happen again without more systemic support for families to be able to provide care.
It also seems that you're saying that most people get one-off help, but that ongoing help, which is often needed, particularly for persons who have a psychosis or schizophrenia. And what is their access to medication, particularly medication like clozapine and risperidone and those types of medications, which are the more advanced now treatments for psychosis in some countries? Are they available to particularly people who do not have money in Indonesia?
Yeah. Yeah, so they are available through primary care centers. Primary care centers are able to provide medications for people with psychosis. I'm not quite sure of the specific drugs that are available. There's still a bit of course, there's always a little bit of challenge in providing and distributing those sorts of drugs, but regulation-wise, it is available at what we call puskesmas, the primary care centers, and it's our way of, that's the strategy to be able to provide this through primary care centers, because we have 21,000 spread throughout Indonesia. Of course, there's different qualities or facilities available at each puskesmas, but that is one of our strategies and opportunities to be able to provide mental health. And I'll talk a little bit more about how we utilize the primary care centers.
Is mental health care covered under the BTheol the health care?
Yes. Short answer is yes. There's a longer explanation to what is covered, how much is covered, but that may be a bit more of a conversation. So maybe for now, I'll just say yes. So part of it, but there are certain limits, and unfortunately, it's not unlimited. So there are certain criteria and limitations to coverage available with BTheol, including the medications for people diagnosed with psychosis, schizophrenia, is covered. Okay. So now. To continue on with what we're talking about, the primary care centers is the health infrastructure in Indonesia. So PHCs, this is the primary health care centers that I was talking about. We have, sorry, it was 10,000, a bit more than I remembered. So 10,000 spread across Indonesia. This is at the Kecamatan, but sub-district level. So Indonesia has province, agencies, districts, sub-districts. So each sub-district will have puskesmas, and sometimes they have two as well. So it depends on the need, but basically that's at the level, governmental level that it's moved on. Now 4,700, which is just a little under 50% of PHs have mental health services, with an asterisk because there is differences in who was available to provide that service. Most of them would be mental health nurses. And we also have primary health care centers where trained GPs, GP+, and also, of course, clinical psychologists in primary care centers as well. General hospitals, the psychiatric units, the 357 across Indonesia, which is actually under 50% of all general hospitals. And we have a tertiary level of mental health care at mental hospitals. So there are certain hospitals that are allocated specifically for mental health cases, although they also serve other healthcare services as well. So there's 51 in 28 provinces. And how many provinces are in Indonesia? Because you know, how many provinces?
38.
38.
Yes, and so there are some provinces do not yet have a mental health hospital, and that is one of the priorities of the Ministry of Health currently is trying to establish these mental health hospitals. There's about 10,000 mental health beds across Indonesia. So
10,000.
Yes. Okay, so this again, distribution matters. We see here the only green kind of area is in Java, where we of course have the most populated people, but there are still people outside of Java and they still have the need to access mental health services. Okay, so when we talk about mental health care, of course we're going to have to talk about the policies. What sort of policies have been made to regulate mental health care? Wait, am I over time? Yes. Sorry.
But it's so interesting.
Okay, sorry. So we've had several changes of regulations. I think one of the most significant ones that I want to point out here is the fourth one from the right, which is the second last one. Undang-Undang, Umum Undang-Undang, number 18. Well, that's 2014, sorry, but 2014. This was a standalone mental health policy And we saw it as a breakthrough, that there was a standalone mental health policy that really covered all these different efforts in mental health on promotion, prevention, intervention, and rehabilitation. But in 2023, the Ministry of Health created a new umbrella regulation that kind of dissolved the previous regulation and then made one whole new regulation on just health, which is supposed to cover mental health as well, but then there's no standalone mental health regulation anymore, and so there is a little bit of a worry that it's kind of lost in there again. But we're still trying to work through maintaining that mental health is a priority in these health regulations. So one of the arguments that we see is that within the standalone mental health regulation then is not as integrated as it should be. And so with this overall umbrella regulation, we're hoping that when it's integrated into the overall health regulations, it can be applied better. It can be better implemented. Thank you. Yes. So that's what we're trying to do right now, is providing regulations that also include mental health in all of these aspects. And also, that's at the national level, and then provinces, regencies, and local governments have the ability to enact their own policies as well regarding mental health care in their own jurisdiction. So there's a bit of wiggle room there for certain local governments. Coverage and expenditure, UHC services is about 50, so okay, but there's room for improvement, of course. It's 2% of the mental health mental health expenditure of percentage of total health. That's only the health expenditure of Indonesia. Only 2% is spent on mental health. And the majority of that goes to primary health care and also mental health centers. Now, one of the things at our center that we try and advocate for is the availability of primary care psychologists or clinical psychologists in primary care, because we see that as a strategic position to provide mental health care for people. And so this is an idea that's kind of spread throughout Indonesia, starting from Yogyakarta. Now there's several provinces that provide psychologists in puskesmas, in primary care centers. Malang, Surabaya, Banten, and Palu. Palu is interesting because that was heavily advocated after the disaster in Palu in 2018. And the earthquake and the soil liquefaction. Anyone? Yeah? Yeah. So if you've heard of it, if you haven't, then Google it. It was a devastating disaster. Quite scary, to be honest. But that was one of the points of advocacy. It was a very traumatic experience for people, and so that's a risk factor for various mental health disorders, and so sustainable mental health services had to be available for people, and one of the advocacies was providing psychologists and processes. So these are some of the services that psychologists can provide. And this is based on in Yogyakarta, so there can be different ones according to different needs of the puskesmas. We have a service for children and adolescents, adults, there's counseling for families, and there's also in Yogyakarta, counseling for premarital counseling is mandatory. So if you're going to get married, we have to have a health check and you have to have a premarital counseling with a psychologist first. So also with pregnant women, so when they report to the puskesmas that they are pregnant, they go through counseling as well to get them ready to take care of themselves, take care of their baby, make sure that they don't have risky birth. Also, actually, that's up here. People who have been diagnosed with HIV, there can be certain behavioral changes that needs to be made, and there's counseling that goes to psychologists, and also, of course, mental disorders we offer no common mental disorders such as anxiety and depression is also available for services at systems. Also management, which I will talk about. I've been diagnosed, for example, with schizophrenia, with psychosis. They rehabilitate through the primary care centers as well. Challenges, there's too many to mention. We have identified most of them. So we'll share this and we can read most of it. I think we've gone through most of it and it's too long. These are some of the recommendations we've made. I think most of them are pretty straightforward about systemic strengthening of the mental health system from regulations and then putting them into implementation and making sure that it is achieved, maintaining common mental health education strategies, of course, about literacy, financing, and other things. Okay, so these are some of the strengths that we have in Indonesia. We do have quite a well organization with program implementation. We have national governments, provincial governments. We work on that system to be able to provide mental health care. Although sometimes the challenge is making them aware of mental health, burden of mental health disorders, can be quite a challenge. We also have a disability law that includes mental disability, is integrated with social services as well, which is opportunity. Some weaknesses, we've talked a lot about that as well. Also that data is very hard to gather accurate data in Indonesia, so it does lead to a challenge in forming the policies and the programs that's really needed. Opportunities. Non-health sectors become increasingly involved in mental health, and this is one of our points of interest in CDMH is how we can include not only health professionals, but people like local leaders, religious leaders, even religious healers and local healers, people who they trust to go to, and how we can collaborate to actually provide mental health care, so they become kind of the first point of access for mental health care. And some threats, of course, not seen as a priority. Okay, so these are some documentaries we've worked with Professor Colucci, working on Harmony Healing Together. This is a documentary about that working together, integration of local religious leaders with mental health care. It's really interesting, available on YouTube, so you can look it up, and also Breaking the Chains, which is all about the confinement and human rights in mental health. So I recommend that too. Okay, so that's probably all from me. I've talked a bit too long. This is time for okay, please give applause for
Okay, we will, next to our presentation for the second presentation, we will focus more on UKP, or Unit Konsultasi Psikologi. It's a mental health services in this faculty that provide service for academic community and also for external clients. And it will be Handoyo, the head of UKP. Mustio will share his expertise on mental health interventions and strategies that are being implemented to improve access to quality mental health services in UGM. Mustio, the floor is yours. Give applause to Mustio.
Okay, so good afternoon. Good afternoon. Okay, so don't worry because I only have 4 slides to cover, including the title. Okay, so I'd like to introduce myself. My name is Restu Tri Handoyo, but you can call me BTheol. And as mentioned by Shasha, I'm currently the head of UKP, Unit Konsultasi Psikologi, meaning in English that would be Psychology Consultations Unit, which is based in the Faculty of Psychology here in Universitas Gadjah Mada. But we also have some collaborations with other parts of the units that providing mental health service across university as well. So what I'm going to talk about is the mental health service not only in UKP but also what we have available in at UGM. Okay. So yeah, because this is I've been told by Mbak Ditya actually to talk in this very special occasions, and being told by Mbak Ditya sometimes can be very pressuring. So here is the 3 slides that is the result of that pressure. Okay, so I would like to start with the management and structure that we have in UGM. Yeah, these are the bureaucracy that we have that related to the mental health services that we have in UGM. The highest authority related to mental health services is called the Integrated Health Service Office. We have which then branched into the 2 separate health service. The health center, for example, it's focusing on more physical health, while the well-being center is more on psychological and mental health services. So under the health center, we have the Gadjah Mada Medical Center and the academic hospital, UGM Academic Hospital. So those are 2 of our biggest resources that we have to provide mental health services, because at Gadjah Mada Medical Center and also the academic hospital, we also have psychologists practicing and providing mental health services as well as of course more specialized service like psychiatrists, neurologists, and so on and so forth. And then under the well-being center, we have the mental health service unit. Yeah, this is the unit that works, have the scope of service includes the whole university. Yeah, and then we also have other resources unit related to well-being center, but I will only mention the mental health service unit because that is the unit that is coordinating all of the mental health service that is available in UGM, including the one that we have in Gadjah Mada Medical Center and also the academic hospital. Meaning that if we have mental health cases in the university involving students or academic staff, we will be notified through the mental health service unit. Okay, so, and these are the mental health resources that we have at UGM. I already mentioned the 3 of these units. The first is I haven't actually mentioned psychology consultations unit because it's not reflected in the the university structure because it's under the faculty. But the psychology consultations unit is also playing I think it's also playing a huge role in terms of providing mental health service in UGM, because we provide what we call as MERL, Mental Health Emergency Response Line, meaning that if students have mental health crisis, then they can call to a hotline that we provide, and then we provide a first response to them, and then we will refer them to the Gadjah Mada Medical Center or to UGM Academic Hospital or to the psychologist that we have at UKP to receive appropriate services. Okay, so and what's unique in psychology consultations unit that it's not only providing service to students and academic staff, but we also provide service to the wider society, the community as well. But of course, because if the clients not coming from the university, then they need to pay for the service. But if the clients are coming from the university, then they can access it in free of cost. So and then the Gadjah Mada Medical Center, this is equivalent to what Alia already mentioned in Puskesmas. Yeah, so this is they also provide healthcare. They have doctors, they have dentists, they also have psychologists there. So students at University Gadjah Mada can go for walk-in sessions, or maybe they want to have a schedule, they can also do that, to a clinical psychologist that is based in the Gadjah Mada Medical Center. And what good is that the service in Gadjah Mada Medical Center is covered by the BPJS, the national insurance, because that's why I say that GMC is equivalent to the puskesmas that we have outside of the university, because the GMC is also providing healthcare for other community members as well, non-students and non-academic staff for the university. And we also have the UGM academic hospitals, which usually we only collaborate with the psychiatric wards and also the psychological service that we have there. So if a student or academic staff is having mental health crisis, then we can send them there, with ambulance if needed. So I think if we want to talk about mental health services, it's all about the resources that we have. And if you compare with what Oli already mentions, that the conditions in Indonesia, in wider Indonesia, we don't really have lots of resources. But in UGM, I think we have more available resources that we can give to our students and academic staff. But of course, please don't compare this to what you have in Sydney Uni, I think we will fail in comparison.
I think you're actually doing a very much more integrated. We might have the student counselling service, but we wouldn't have the connection to the other or tertiary end of mental health. We've seen it play out in where that is okay.
Thank you for the encouragement, but actually I'm only being humble. Actually, thank you so much. And the services continues developing actually, because the mental health service unit that we have in the university is under development, and we're still creating new systems, such as the mental health screening that we have in the university right now. So we are doing mandatory mental health screening actually for all of our students. And this is carried out in semester, if you're familiar with that, but of course not. It's the UGM academic system in which you want to, let's say that you want to enroll to a course, then you need to enroll it through the semester. In that system, we plan a mental health screening, which active students should complete at least once a year. It's been mandated by the university for the students to do so. By doing so, we have the complete data, or what we call it, the demographic information about the mental health of each of the students. But of course, only if they report agree and then report the conditions as is. If they're they don't report what they experience. Honestly, of course, we don't have the valid data, but at least we have a way to identify students who has high risk of mental health problems, and then we can do more early interventions on that as well, of course by consent. And then we have the mental health crisis response and case management. This is currently being done in UKP, the psychology consultations unit. But in the future, this will be placed in here, the newly established mental health service unit. But here, still not having mental health service unit. So the main idea is that when students or staff is currently having mental health crisis, then they can call the hotlines, and then we monitor the case and also the conditions and also the treatment that is given by the students, given to the students or the staff. So if the patients was referred to the MC or the academic hospital, we will still be notified of the results of the treatments. So we know where the patient is, the current situations, and so on. So we know what to do, because of course, in dealing with mental health crisis cases, it's not something that you can, finish or cure instantly. It's a process, and sometimes it can be a lifelong process. Yeah, and if you're a student, yeah, you have lots of stressor during your academic life as well. Yeah, so I think that's why it is important to be monitoring on each of the cases. And then mental health promotions as well. We have programs to increase mental health awareness and literacy, including webinar workshop trainings that we do for faculties across UGM, and also to facilitate faculties to increase their mental health capacity by endorsing them to hire a psychologist. Yeah, we are endorsing all the faculty in UGM to hire at least one psychologist, so they can play a role as a mental health case manager. Yeah, so if a student or 2 or 3 or 5 students from their faculty is having mental health crisis or mental health problem, at least we know who to talk with. Yeah. Yeah, that's all. So as promised, it's only 3 slides. Back to Sasha, I think, for the Q&A.
Okay, thank you, Mas Theo. That's the end. And we know we'll open the sessions for Q&A, for questions. And this is, I think, a great opportunity to engage with our speakers and maybe look deeper for the topic that we are discussed before. And if you have any questions, please raise your hand. And once called, kindly state your name and your institutions. Anyone want to ask? Okay.
Thank you for the opportunities. My name is Anindia. I am from Universitas Gadjah Mada. I want to ask a question. So,
wait. I think there's a problem with the mic.
So when we're talking about mental health, it's in the very beginning of the first speaker, we talking about the taboo things, and then we also talking about the confinement of the mental health. Back in my hometown, mental health is not a common thing to talk. Like the society there, including my parents, is not really aware about the mental health. So it's really hard for us to express if we have a mental health issue. So the question is, how can we raise the awareness of the society and our parents, the generation before us? Because I believe that mental health is common to the young people or the youth generation, but not with my parents' generation. So how can we raise the awareness among them so that it's easier for us to talk if we have a mental health issue? Thank you.
Okay, thank you, Anindia. Anyone else? Okay, maybe you can try to answer for these questions. But yeah, please.
Okay, Anindia, thank you very much. It's a very, very important question. And so about literacy and how we can provide good mental health literacy to everyone with different communities with different locations, and that's why, again, we advocate for placing of psychologists in puskesmas, because it's not only treatment that they are able to provide, but also psychoeducation, right? Having a psychologist in puskesmas opens up people's options to various healthcare. So, for example, someone might, and this is often what we meet, is that people come in with physical complaints, unexplained physical complaints, and then gone to the doctor, to the GP several times. It's not getting any better. And so the GP goes, there might be something more psychological to this complaint, and then they can refer to the psychologist's question. And I think having that experience, having people go through that experience can help also kind of, in a way, spread the word about mental health and services that are available to them. Of course, it's still a big challenge, but we do think that this is one of the strongest strategies that we are trying to advocate for. That answers the question. And also, I don't know, also is again working with local leaders, working with religious leaders, because we have a very religiously influenced communities, and it's so important to bring them in and help them, and also let them work together, basically. Meeting at a point where we have common ground of mental health problems and how they are burdened to society, and how the way forward for helping people understand their mental health.
Okay, maybe for Master, you want to add something?
Okay, just a little bit maybe. I think what we need to increase the exposure to mental health discussions, yeah. Because I think it's already a hot topic among Gen Z, but if you're talking about previous generations, the older generations, maybe what we can do is, of course, increase the exposure to mental health topic. We can use, of course, social media, but I think what we need to do is to be really careful, yeah. But because using social media can also, give wrong information about mental health. So if you're enthusiastic in increasing the literacy of mental health among lay people, then we can use social media and then try to provide accurate information about mental health, what is mental health, and then of course battling stigma, because I think stigma is one of the thick barrier that we have in Indonesian society. Because in previous generations, I think we still think that mental health problem is a taboo and things like that. So I think that. Thank you for the questions.
Okay, thank you, Mas Tio, for the answer. Anyone else want to ask questions to our speakers?
Hi, my name is Margaret Spencer. I'm from the University of Sydney, and I was wondering that I think a newer approach to addiction in health is that addiction is classed as a mental health issue. And I was wondering if it's seen that way in Indonesia, or if that is a common way of looking at addiction. Thank you.
Okay, thank you for the questions. Maybe Mr. Orlando want to answer.
Yeah, so it's hard to say, but I will start from kind of the top. The Ministry of Health, the directorate that handles mental health, so it's so the mental health as the directorate is also the directorate for BTheol, which is the substance abuse. So I guess in a way, looking at policies and government position on and views on addiction, it is very much related to mental health care. But I guess the implementation would you say it's integrated as ideal as it should?
I think it's not that ideal, but in a not substance abuse ministry.
There's also special government body,
yeah, and they provide consultations for the patients, but it's not that's not a mandatory. So if the patients need some consultations, they will help them to go through the process only for like.
Yeah, so maybe we should talk about what addictions is first, and what substance or what things that we're addicted with. Yeah. So if it's we're talking about smoking, and then we talk about substances that are legal in Indonesia, then yes, we can see that as a mental health problem. But in Indonesia, I think it's really related on how the law works over here with like the substance use. Yeah, we currently don't have any legalized substance yeah, aside from nicotine, which is smoking, yeah. But including marijuana, it's illegal here. Yeah, it's illegal here, including even in medical purposes, we are very careful on using those kind of substance as well. It's only for medications purpose, but for recreational sense and other situations, it's completely illegal. Yeah, correct me if I'm wrong. Okay? So in those contexts, yeah, the treatments for addictions for illegal substance, it will be integrated with the law and justice systems. Yeah. Sometimes the judge will give the punishments including the rehabilitation process in which the patients are like asked to go into what you call it therapy to work with the addictions problems. So to make sure that they don't use the substance anymore after the what you call it the punishments. Yeah. So I think that's what I can say. But if we're talking about addictions to smoking, yeah, or other stuff like gaming, gaming, I think there are some phenomena that are being portrayed in newspapers, or some children that are addicted to gadgets and something like that, and then that's are treated as a mental health issue. So psychologists are working with them, yeah, and then aside from social workers as well, of course, and then yeah. So I think that's the what I can add here. So I think it's important to see the context, what kind of addiction that we're talking about, because in Indonesia, again, substance use is very strictly regulated, and if we're talking about addictions related to illegal substance, then the treatment will be integrated with the justice systems as well.
Okay, it's okay, just a little bit. If we're talking about substance abuse, rehabilitative services are available, but it's what we call institutions that have to report. So there is no way that a person who is addicted, uses substances, to access healthcare without not being implicated by their behaviors.
So they can't, so say for example you are addicted to an illicit drug, you can't just put yourself into rehab like the Hollywood stars here. You are going to actually end up with a criminally charged. So it makes it actually really difficult for people who, yeah, and I suspect that would also be in the upper echelons of the society more probably than the poorer people, because they're the ones who may have access to clubbing drugs like cocaine and stuff like that. And would that be correct?
Drug use is also rampant against low-level communities as well. Particularly in areas where it is quite readily available. It's not so, from what I know, very limited. I don't have a lot of knowledge of that, but it's actually quite, there's access to illicit drugs. And maybe this is not exactly answering that question, but I think it's also how we view the government body, the BTheol who control, whose job is to regulate the distribution of such drugs. There's that balance of regulating drugs and providing healthcare for people who are abusers. That can be a bit of a difficult balance there, I guess.
That thing between what is a health issue, what is a social issue,
exactly,
and what's criminalised.
Yes.
And how do we manage something as a health issue as opposed to as a legal issue?
Yeah. Okay. Is that it? Okay. The next question.
How open is the government to collaboration with mental health professionals on new policies towards bettering mental health? Is it more they say something and you have to do what they say, or is it like they're open to the ideas that you bring to them?
It's a very
I think we only should allow easy questions to be asked.
It's difficult one. It's a difficult answer. It's a very difficult answer because decision making is affected by various things. It's not just affected by their willingness to collaborate with mental health professionals, but also about political decisions, definitely funding, those. That's always going to influence decision making, and in our experiences also. Sometimes in advocacy, when the different levels of government will also need different levels of information. It's really about knowing what they need as well, meeting them at where they want to go. And sometimes it's also a little like compromising with the situation. You're not always going to be able to push for the most ideal option. But it's it's one small step at a time that we need to, when we're advocating with governments at different levels. Does that kind of a little bit answer your question?
Very safe.
Okay. Okay, I think there was a... Okay.
Okay, thank you. I want to differ from the analyst. I think mental health is a hot topic among adolescents or social media users, I think. They have awareness, but unfortunately, the information about mental health not delivered by professionals, but delivered by they who have a competence about mental health. It could increase self-diagnose, and they try to solve it by himself. And what you think about it, and how could policies do with these situations? Thank you.
I think this is your topic, Ali, so you should ask. Well, okay, so I'll try to answer the questions. First is about the, I think it's related to regulations about psychological service, yeah, in Indonesia. So I think we already have the law, specific law about the what is it in English? So it's a law on practice and education in psychology. So basically we already have that. Previously we don't have that. So I think that's lots people who do practices, mental health practices without having the credential as a psychologist and so on and so forth. Yeah, so what do I think about that? Well, because we already have the regulations, so I think we should abide to the regulations. Yeah, what the regulations says about what is psychologist and what they can provide as a service, then that we should abide. Yeah, if other professions also provide similar services, yeah, for example, like what do you call it, counseling. Yeah, of course we have different counseling process, and that can also be carried out by different professions as well. Yeah. From what I know in Indonesia, I think the pekerja sosial, the social worker, in Indonesia also do counseling. Yeah, and also teacher. Yeah, teacher also do counseling. So as long as there are clear regulations on that some professions are allowed to do those practices and also gain profits from that, then that's fine. Yeah, as long as they have the standard and it brings benefit to the clients. Yeah, I think that's the common ground that we should have. Yeah, first the regulations, and also of course that the process is benefiting the clients, and also we need to have some kind of standards on that. And what was the second question again? Sorry. Because Alia mentioned stigma, but I didn't catch that in your question. Self-diagnosis. Yeah, my positions in self-diagnosis is I'm kind of in the middle. Yeah, because having someone self-diagnosing themselves means that they have, to some extent, good mental health literacy, meaning that they know the information about diagnosis, the symptoms, yeah, and then they are, they're assessing themselves, assessing their situation. That's a good thing, yeah. But if the self-diagnosis, then it leads to something negative, such as like self-fulfilling prophecies, yeah, without being validated by professionals, that might not be something that we need to endorse. Yeah. So to some extent, that's a good sign. The phenomenon is a good sign. But of course, you will need to validate that to our professionals. Yeah. Because I think the negative side is that if you're diagnosing yourself and then being occupied by your own diagnosis without knowing whether you have the conditions or not, and then you're not getting treatments as well, then that's bad. Yeah. I think that's where I stand in this kind of issues. Okay. So thank you.
Okay. Thank you, Mr. for the answer. For the next questions, I think
hello, my name is Simone. I'm from the University of Sydney. My name is Simone. I'm from the University of Sydney. I was wondering how it goes in terms of law, how they go about working with mental health professionals in court. Like, is there a process for pleading insanity or getting a reduced sentence because of having a mental health condition? I know that might be a bit more of a law question than a psychology question.
Sorry, can you say that again, the question?
Is there a process for pleading insanity if you've committed a crime because of possibly experiencing psychosis? Is there a process for that in Indonesia?
Forensic psychology, of course, yeah. We do have that, yeah, but it really depends on the judge. Yeah, the judge say that if they invite what we call as saksi ahli, an expert witness, which usually a psychiatrist and a psychologist, to assess the what do you call it, the clients. Then yeah, of course we can do that. Yeah, and that's occasionally happen in cases in which mental health conditions are considered as an issue. Yeah. For example, what I know is that we usually when we have a perpetrator who is has intellectual disability, for example. Yeah. And also one case that I'm also involved is it was a case of what we call it exhibitionism. Yeah. So I also assessed the clients and then said that yes, the clients based on our assessment, the clients is can be diagnosed as having sexual disorder conditions, exhibitionism, and then that becomes a part of the judge considerations in making the what you call it decisions. Sentence. Yeah. So yeah, that's the process we have.
Okay. Oh, the girl in the group. Yeah.
Okay. Hello, I'm Mason. I'm from the University of Sydney, and yeah, my question was with continuing to address systematic barriers in promoting mental health and awareness. I'm just really curious, do peer-led support groups or activism groups exist where people with lived experiences of mental health could meet together, or not really because of shame and stigma?
Yeah, so yes, definitely. I think consumer groups are very great advocates for their issues. We have several that we identified untuk KPSI, so keluarga, family, keluarga, peneliti. Yeah, it's an abbreviation, but there's schizophrenia in it. So it originally KPSI, so they have chapters all over Indonesia. Great resource if you're interested to know more about them. And they originally want to focus on the schizophrenia, but they've recently kind of spread to other mental health issues as well. Another one that we work often with is Bipolar Care Indonesia, BTheol. There's also Into the Light, which is looking at suicide and self-harm, especially young people. OCD, okay. Okay, so support for OCD as well. So I think these are great resources and support communities for people. We often work with them as well in research and advocacy as well. Again, sometimes there is a bit of concentration in big cities, most populous areas, of course, but also with the availability of social media, it's become a lot better for people to communicate with these communities.
Okay. Sorry. My name is my name is Lily. I'm also from Sydney Uni. And I kind of have two questions, but I don't know if that's really
Let's get into questions. Go ahead.
So my first question is that obviously there are a lot of stigmas around mental health in Indonesia, which affects like people going and getting help in the first place. But my question is do you think that the stigmas also then affect whether people take their medication even after they've gone to the doctors? And if so, is medication like SSRIs, TCAs, is that the best approach to treatment of mental disorders in Australia, or are like more cognitive-based therapies a better way to go about treating people who have got mental health issues? And then
that was the first one.
Yeah.
What was the second one? Choose the easiest one.
You might ask the second question. My second one is that like throughout Indonesia, obviously there are a lot of different like cultural groups. So do you have one like nationwide diagnostic manual like the DSM-5 or not? And if so, also is your like are your diagnostic manuals influenced by local cultures and like practices?
So I'll take the second question because I think this is a bit easier. I'll help you with the first one. Okay, fair enough. Okay, so in Indonesia they have what we call S.Psi. So it's a diagnostic manual that is developed locally in Indonesia, although it's a derivation from ICD actually. But it's actually that is the formal diagnostic manual that we have. Yeah. So for example, like if but only if you're working in hospitals. Yeah, you're working with different mental health professions, for example. So let's say that I'm working in a hospital and I'm working on a patient with a psychiatrist. Then what we use usually is the PPDGJ. So it's I don't know what the English word for that, but basically that's a diagnostic manual for mental disorder. Yeah. So and then but if you're working independently as in a private clinic as a psychologist, sometimes you can also use DSM, yeah, because the problem with our PPD is that it's quite old, yeah, and we're still working on more recent versions where it's still updated, ongoing, the process is still ongoing. but we still use that, yeah, in practice, in multidisciplinary practice, especially in hospitals. So what we teach our students, yeah, here in the faculty, especially our profession students, yeah, we teach them how to do diagnosis in first, of course, the PDG, yeah, and then we also usually use DSM, yeah, as a secondary diagnostic reference. Yeah, I think that's your questions.
Yeah.
I think I want to ask some answer.
You want to ask?
Add.
You want to add? Okay. Feel free to add.
I was once work at Puskesmas as a psychologist, and they use ICD-10 because we work with other we work with other healthcare professionals. So we use ICD-10 also because
World Health Organization.
Yes. Yeah. With ICD-10, not only with the BTheol or DSM, but we use ICD-10 also in a healthcare, primary healthcare. Okay, and for the first questions.
Medication versus therapy.
Yeah, I didn't have a straightforward answer for that. From what I know, medications can certainly be a less stigmatizing option for people, and that's why also the pathway for treatment in Indonesia is usually from a GP, from a primary care center. They can refer to general hospital if they have psychiatric units, and then at the tertiary level there's usually psychiatrists there. And psychiatrists do tend to provide medications. But I think this might be an additional issue, but there's, I think, less conversation about side effects and good understanding of these drugs that are being given to patients, because some of the time we see that patients who have been prescribed medication but not provided enough information about its effects and side effects and how they can function with these medicines. So I think that's kind of my concern sometimes with this, although of course it's needed, but there's also needed education with management of these medications. We had for the treatment between psychological therapies and other pharmacotherapy, but I was mentioned that there was a research done comparing GPs trained in the WHO MH gap, so GP plus compared with usual treatment with psychologists in primary care settings, and it showed that GPs was not inferior to psychological treatment as usual, but there was indication that psychologists are more cost benefit, has more value cost benefit. That's a little bit of a snippet. It doesn't answer the whole question, but it's like one piece of the puzzle, I guess.
Yeah, I'd like to add something. So actually, for medications, because the questions also ask about effectiveness, yeah. So is it effective to use medications as a treatment? So I want to talk about this in a more contextualized issues, yeah, in traditional community. I think one of the challenges that whether it's not whether it's stigmatized, yeah, but it's more about the beliefs about medications, yeah, beliefs about the effectiveness, beliefs about the that drugs contain chemicals which is bad for your body, and then we have this alternative, medications that they use, yeah, traditional practices, which doesn't always really helpful, yeah. So sometimes the patients and the family members discourage the use of medications not because they stigma, yeah, but it's it's not aligned with their beliefs, yeah, their traditional belief that there are more effective way of curing these conditions. That's one. And then second one is that the perceptions about taking medications is that the medications help you to cure the conditions. Yeah. So if a patients come with the influenza, of course the medications can be like eliminate the symptoms. But if we're talking about schizophrenia or other severe mental disorder, then the drug's function is to manage the symptoms. Yeah, it's not eliminating the symptoms, but it manages the symptoms. In which, in traditional communities, the perception is not like that. So, yeah. So the idea of consuming medications for lifelong conditions, it's bad because it's full of chemicals. There's an alternative way of curing and so on and so forth. So yeah, I think it's a topic that I want to add in the discussion. So hopefully that also provides a more broader context in this discussion. Thank you.
Thank you. Okay, I think one last question. Yeah.
I'll keep it simple. I saw you guys do work to minimize barriers to mental health care. I just wanted to ask, in your advocacy, do you take a more medicalized look view of mental health, or do you take a social view towards mental health? Because it's hard to have good mental health if you live in poverty, or if you're stressed about housing, or if there's gender violence against women. And in doing both advocacy for mental health, you also advocate for welfare services and against gender violence, so that the flow on does improve mental health. Is that hard?
Well, it is a complicated issue, right? Mental health is, it's linked with all these other social issues. But I think in our journey, in our experience, is because where our expertise is in psychology and services, it's just a much more effective way to advocate for the issues that we are most experiencing. And so I think it's valid to point out there's all these biopsychosocial understanding of mental health, but when we're advocating for an issue, we do tend to provide a message that's more practical, that's more technical, because it's something that there's a clear vision of what we're advocating for, rather than because then it gets too broad and it might be overwhelmed for people to understand, we have to do all these things. So it's a step-by-step sort of process.
Thank you. It'll be an interesting question to ask when you go to speak with the social work program, what they think in terms of the approach, the psychologists, and that's where having a multidisciplinary team allows for sort of a more diverse way, a holistic way of working with people. I know that was the last question, but I think that I just have one last question, which was about, you said suicide and self-harm, there's no eligibility for treatment, and I want to know why. Oh, insurance. Yes. Insurance.
Yeah. I don't know why, to be honest, but my assumptions of the thinking or the logic is that it was, in a way, committed by that person themselves, and there's that aspect of self-harm, and again, that not understanding what goes on behind that self-harm or the cause of those behaviors that then creates decisions like that. Yeah.
And because we are very limited in resources, of course, and because I think Indonesia, I think we also want to add for the previous questions, yeah. Of course, we advocate on all aspects that related to mental health. Yeah, if we want, of course, that's the ideal situations. But in Indonesia, resources are always limited. Yeah, we have. I think Ali already mentions the health budgets. Yeah, allocated for mental health. It's only a small fraction of it. Exactly, a very small fractions of the whole budget. Yeah. So if we want to address mental health with its broad correlates factors that are shaping mental health. Of course, we want that, but given the limited resources that then we need to prioritize which aspect that we need to tackle first. Yeah, and including the suicide and self-harm treatment. Why the insurance didn't cover that? Again, we don't know about the logic behind these decisions, but we can assume that because given that the insurance that is used for all of the citizens, yeah, which has a disease that is not inflicted by themselves, yeah. So once a persons are assumed to be inflicted by the disease or the conditions are inflicted by themselves, then that becomes what we call it, reasons to deny access to health free for the insurance. So I think that's that. Yeah. But of course, if we do have more resources on our hand, yeah, of course we would like to cover all of that as well, including conditions that are related to suicide and self-harm as well.
So it still seems from a very punitive perspective, someone can't see the hospital having harmed themselves, you've done this to yourself, you deserve to.
Yeah, maybe.
I'm conscious we've taken up overtime.
Okay, as we approach the end of our program, thank you Mas Tio and Mbak Alia for the insightful presentations.
Thank you for all the hard questions.
Okay, I would like to take a moment to reflect on the key takeaways from today's event. We have discussed the pressing issues surrounding mental health in UGM and also in Indonesia, explored various initiatives aimed at improving mental health services, and engaged in meaningful discussions. We highlight the importance of collaborations efforts. And thank you everyone for the participation. Special thanks to the University of Sydney and the Faculty of Psychology Universitas Gadjah Mada for organizing these meaningful events. We hope that today's program has provided you with new insight and also the inspirations to continue working on improving mental health. And also let's us carry forward the knowledge and the ideas shared today and apply them in our respective fields. Thank you once again for joining us, and we wish you a pleasant afternoon and look forward to seeing you at future events.